This is Dr. Craig, and welcome to Top 10 Radiology.
Okay, let's go over our last cancer, which is endometrial. Um, Endometrial cancer is typically actually done by FIGO, which is a surgical basis, but it is listed as TNM. It can be done as TNM, and there's ways to kind of interlap the two. So I just kind of combined the important parts of the TNM for the ease of our reading. So in this case, T staging includes extension into the myometrium, which is less than or greater than 50%. This is actually going to be a really large challenge because in postmenopausal women, the uterus is typically a little bit smaller, and you lose kind of the good anatomy that you would see in a premenopausal woman. And so you kind of have to give your best estimate. And then you want to think about other things such as the cervix, because it can go down or out, and then serosa, vagina, and then bladder and rectum. So it's just kind of all local spread of disease. For end staging, we're thinking regional Mets, which is pelvic as well as para-aortic, and that's kind of different than the standard prostate or rectal, where the upper retroperitoneal lymph nodes are usually excluded. And then for metastatic sites, we're thinking intraperitoneal metastases, or including peritoneal or omentum Mets. So you're looking for soft tissue nodules there. And then followed by the lungs to bone. And you can see that it's a lot higher incidence of intraperitoneal Mets than the final two. Pearls here are that the most common lymph nodes are periaortic, and supraclavicular nodes can be seen in 10% of stage 4B. So it's one spot that you just don't want to miss looking for. Okay, so before going into endometrial cancer, I just want to show you a few basics of imaging the endometrium, and a little bit of pelvic MRI history here. So here is a premenopausal woman, which you'll see, which is actually relatively easy to tell because of the tri-layered appearance of the endometrium here, or the uterus. So what we're looking first is the endometrial canal, or endometrial. Yeah, I like to say endometrial canal because it leads to the fallopian tubes. Some people say cavity. And so that's kind of this like grayish or T2 intermediate signal. Immediately around that is the junctional zone. And so this is the measurements that we talk about when we're thinking about adenomyosis, which is that endometrial glands projecting within the myometrium. And then outside of the junctional zone, we have the myometrium proper, and then we have the serosal layer here. So if you look at enhancement patterns, enhancement of the uterus can significantly vary, but it's important here when we're talking about the setting of endometrial cancer that there's no enhancement at all seen within this the endometrium itself. And then looking at restricted diffusion, so it is bright signal here, but it's kind of you see it's bright, but then we go to the ADC and we see that it's also bright. So this is T2 shine through. Okay, and now we have a postmenopausal female with endometrial cancer. And so what you see here immediately is we kind of lose that nice layered appearance of the uterus, which is normal after postmenopause, or can be seen after postmenopause. Then we're looking here in the endometrium, and the endometrium is distended for age if she's postmenopausal and bleeding. This is definitely abnormal. But what you can see here as we go up, you see that the endometrium looks like it's extending out, which is completely abnormal. Let's go to contrast. And so if you look here at contrast enhancement, you'll have to trust me on this, but this isn't dark. This is intermediate signal. So this is telling me that there's something enhancing and that's extending up. And this can be confirmed with restricted diffusion. If you look here, there's the cervix. We go here, and this bright signal looks like it's extending into the fallopian tube on the left there. And again, you don't want to be tricked by thinking that's shine through, because it's absolutely not. If you look here on ADC, you'll see that there's low signal. If you can imagine it, it's at least not bright, is what we can say. And so as a result, that's actually an endometrial mass that's that's extending upwards and out into the myometrium. Okay, so let's look at case number 2 of endometrial cancer. This person has been treated in the past. As you can see here, here's the vaginal cuff, and there's no uterus, so clearly prior hysterectomy. So if we look for nodal disease of the pelvis, which would be considered regional as within the pelvis or para-aortic, is we would be looking for any type of abnormal shaped lymph nodes. And normally here we see just a normal reniform shape, but as we follow the external iliac right here and here, you see ones that are very much rounded or abnormal in appearance. So these are highly suspicious for malignancy. As we go up, we see more para-aortic. They've had a prior lymph node dissection as these show, but there's more para-aortic nodes here, which are considered regional in this case. And so if I'm thinking about that, I want to look after staging nodal, and I want to think about metastatic disease. And so peritoneum being the number one spot, I'm going to just be kind of looking in general of anywhere here, kind of along the omentum. I was told by a very intelligent radiologist that the left upper quadrant, this fat here, should just be nice and clean. It shouldn't have any type of nodularity. And as you can see here, there isn't any type of nodularity. So I'm not really suspicious. As we go through, there's a little bit more fat straining than I'd expect, but again, still no definite peritoneal disease. And then doing a quick run of the lung bases on non-lung windows, you can see that there are multiple sub 5 millimeter pulmonary nodules here in the lung bases, which is kind of concerning considering that lungs show up in 22 to 29% of cases. So in this case, these were called indeterminate. I would definitely compare them to prior if I saw them on first sight. But I would throw in that these, given the distribution of malignancy, this is moderately suspicious for metastatic disease. Okay, this is the last case. It was a great case of cancer of unknown origin. So it was a generalized study and almost an eye test because they didn't really know what malignancy was there, but it was later found out to be endometrial. So I'll start at the pelvis here. This is the first clue of abnormal appearance is there's just way too much soft tissue in this region, and on pelvic MRI later on it showed that it was a mass extending from the endometrium and kind of encompassing the left ovary there, so that was a different staging matter. And so looking around the pelvis for any type of nodal disease, again, follow the vessels because that's the easiest way you're going to find it. There's some obturator lymph nodes. These are the nice reniform shape lymph nodes that are non-enlarged as in contrast to the rounded ones. Again, I called them as present and not necessarily malignant. As I follow up, I didn't necessarily see any abnormal para-aortic nodes. The one thing that should have caught your eye as we go through here is all of this peritoneal oromental deposits, as you can see here. And so this is highly concerning for peritoneal or omental deposits, and I gave a measurement, and that's how they did a biopsy based on ultrasound of this guy, I believe. And then knowing how endometrial cancer spread, my second spot again was looking at the lungs. And while there are a few weird things going on here, this is like kind of a ground glass nodule. There's another one. This person has a background emphysema, which makes things challenging, and thin wall cyst with a tiny vessel running through it, so that wasn't really suspicious. But the last thing that I saw that was highly suspicious was this kind of prevascular or upper paratracheal node that just looked completely abnormal. And so I reported it as such, and maybe they might get a biopsy on that for later time to ensure that is actually metastatic disease or not.